Coming up, new hope for a horrendous disease. But curing sickle cell disease comes with its own hurdles. Today, we explore the remarkable breakthroughs helping some patients escape an early death. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Living with sickle cell disease can feel like torture. There's frequent pain, constant doctor's visits, and unfortunately, a shorter lifespan. It can be cured, though, but access remains a huge issue for many patients out there. Today, we're going to ask why that is. And we're learning about brand new gene therapies that can fix the faults in your underlying genetic code. It's an important conversation, particularly for communities of color, specifically Black and Hispanic Americans. And we also need to review a new FDA warning on CAR T-cell therapy, a cancer treatment that we have talked a lot about on this program, so we'll hear more about that today. And to talk more about all of these conversations today is one of our favorite guests, Dr. Joseph McGurk. He is an expert in blood and bone marrow disorders. He is the division director of HMCT. This is where I have to get your big title out, hematological malignancies and cellular therapeutics. He is with us here at the University of Kansas Health System. How are you?
Very well, thank you, and very well stated.
Thank you. Gosh, coming from you, I know that's a big one on a Monday. So him and his team and his program, they spend a lot of time doing a lot of amazing things in the world of blood and marrow transplants. And one of the members of that BMT team is Dr. Zahra Mahmoud Jafari, a clinical pharmacy manager here at the health system. Doctor, good morning. How are you?
Good morning. Thank you for having me.
Good to see you. And all these new drugs and immunotherapies, they keep you very busy, I know. So it's really good to have both of you here to kind of explain what all of this means. And we are also looking forward to catching up and hearing from Desiree Ramirez. She joins us remotely this morning. She lived with sickle cell disease until she got a bone marrow transplant back in 2016. So Desiree, good morning. How are you?
Good morning. I'm doing well.
Good to see you. I know Dr. McGurk is glad to see you doing well as well.
She looks absolutely fabulous.
Doesn't she look good?
And even more fabulous is her rising career.
Yes. She's starting a new job today, so that's always a very, very good thing today. So, Desiree, how are you doing? Just how are you feeling?
I'm feeling so much better since I've had transplant. I haven't been in the hospital at all since.
We like to hear that. Sickle cell disease, or SCD, is a very literal name, Dr. McGurk. It causes our normally smooth and round blood cells to turn into the shape of a sickle or a crescent. Dr. McGurk, what kind of problems do those sharp, pointy blood cells cause inside the body?
They stack up like pennies. So normally they're nice and smooth and malleable, and they make their way through blood vessels carrying oxygen and carrying waste products away. But when they sickle like that, because of the genetic abnormality, they stack up like a stack of pennies, and they obstruct the blood vessels. They cause serious damage to organs because the organ can't get an appropriate blood supply, and tissues become damaged and die. And so it is an extremely serious disease that has a shortened life expectancy of only 42 years. And for many, many patients, it can be a life of great suffering.
So can you explain the genetic aspect of sickle cell disease? How is it inherited?
Absolutely. It's a single abnormality in a single molecule of the DNA in a piece of the DNA that codes for a protein, one of the proteins that make up a molecule called hemoglobin. And hemoglobin's job is to grab a hold of oxygen from the lungs and have it taken out to the tissues to deliver, so you get oxygen to your heart, your lungs, your liver. And that single abnormality in a single molecule causes the hemoglobin to become misshapen. And so when it's misshapen, it causes this sickling problem, particularly when there's any stress in the patient. It will precipitate a crisis for them.
So why specifically does this happen more in Hispanics or African Americans?
Well, it's most common on a global scale in sub-Saharan Africa. And it appears that having one of these genes, and the problem with sickle cell disease is they get one from mom and one from dad, and both of their genes are abnormal. But getting one of these genes appears to be protective from the effects of malaria, a common infection. And so it was selected for over tens of thousands of years, and it's been propagated in the population because it does actually, in that situation, offer some advantages, but not when the two genes are inherited together. And so most people affected in the world are in sub-Saharan Africa, the Mediterranean basin, and India. In the United States, it affects about 100,000 people a year, about 1,500 people in the Kansas City metropolitan area, and that's not including, obviously, the entire state of Kansas.
Do we know if it affects men or women more?
I don't know that it affects men or women more, so I can't represent that to you. It should be about an equal distribution because mother and father, it's a random selection.
Very random, okay. Yes. But we do know it can be cured,
Absolutely.
With a bone marrow transplant.
That's correct.
We followed Desiree Ramirez during her transplant back in 2016. She was 23 years old at the time. Let's listen to how she described the disease back in 2016, and then we're going to hear her comment from a few years after her transplant.
You're in and out of the hospital, you are in and out of emergency rooms, you always have doctor's visits, you're always like going through stuff, you have infections, you feel really tired, you're in a lot of pain, and most of the time people don't understand the pain. Bone marrow transplant has helped me a lot. It has really improved my life tremendously. I don't wake up in pain, I don't go to sleep in pain, I'm not in the hospital every month, every holiday. It's just a lot better.
And we are hearing from Desiree this morning. Desiree, what's it like to see yourself and hear yourself from back then?
Honestly, it makes me a little emotional. It's true. Like, you're in and out of the hospital, you're in a lot of pain, you're going through a lot. It was like every holiday I was in the hospital or I had a sickle cell crisis. So I'm just very thankful that I'm not going through that anymore. And you can even tell the difference in how I look as well.
You look great. You mentioned it, you talked about in and out of hospitals, but more really, what was growing up like?
So growing up with sickle cell was terrible. I was in pain all the time. I got infections all the time. I was made fun of because I was jaundiced, and it was just horrible.
What advice would you have for somebody going through this, a young person especially?
A young person going through this, I would tell them that there's hope for one. You know, there is a cure for sickle cell disease. You can get a bone marrow transplant if you have a donor, but I would just tell them to remain positive and know that everything will be okay.
And who was your donor, Desiree?
So I don't know who my donor is. I believe she wants to remain anonymous. I write her through my transplant coordinator, but I haven't heard back from her, but I will forever be grateful for her.
Oh, I would imagine. You said you write letters. What kind of things do you say and share with her?
I just express gratitude to her and tell her how thankful I am and how she's changed my life.
I'm sure she loves hearing that. So I know you have to run. We had mentioned you're starting a new job this morning, so that's fantastic. Congrats to that. But before we let you go, is there anything else that you want us to know or really understand about folks who have sickle cell?
Yeah, I want people to understand that sickle cell is a debilitating disease, that it's inherited. It's not something that people choose to have, but I want them to know that there is a cure.
So glad to see you this morning, Desiree. Stay in touch and stay well.
Thank you.
Hi, Desiree.
Hi.
Dr. McGurk wanted to tell you goodbye. You got to come see him sometime.
Bye.
Always good to see people doing well, right?
Oh my gosh.
In your world, I mean,
yes,
you follow people through these.
It's miraculous to see Desiree, and it's fantastic. But there's a great injustice associated with sickle cell disease. Many great injustices, actually. When you look at the fact that we have had for many years now a curative therapy in the form of stem cell transplant, using somebody else as a donor, how many in one of the largest transplant programs in the nation and in the world, here at University of Kansas Health System. How many sickle cell disease patients have we transplanted in that time frame since Desiree had her transplant? 4. How many should we have transplanted? Hundreds.
And let's talk about donors and how hard it is to find a donor.
So it is very challenging. The chance of having a sibling in the family who's not affected by sickle cell disease is about 20%, 15 to 20%. And the family member donor who's who's well matched and doesn't have sickle cell disease is the optimal donor for the patient because of a complication called graft-versus-host disease. But most people won't have that donor. There's a worldwide registry of donors, about 40 million people willing to donate stem cells for someone in need of a transplant. If you're Caucasian Western European descent, the chance of having a match is 75 to 80%. If you're African American descent, it's about 29%. And so there too, not many people are going to have a match in the unrelated donor registry. But we have fantastic new news about newer options, including using mismatched family members and allowing us to do haploidentical transplants from family members. That gives you broad choices. And what we've shown just this past December at the largest blood cancer and blood disorders meeting in the world, American Society of Hematology meeting, that 90% of patients after allogeneic stem cell transplant at 2 years follow-up are like Desiree without symptoms, and the overall survival exceeds 95%. So it's really a stunning time, and mismatched transplants are safe and highly effective in these patients, and that opens the door for everybody with sickle cell disease.
So that jumps you out of bed in the morning, right? Gets you excited.
Absolutely, you betcha.
So also exciting are two new gene therapies. Just last month, the FDA approved these for sickle cell disease. What are they?
They are based on our understanding of that genetic abnormality I described earlier in the gene that gives rise to this malformed protein. Now, neither of these fix that problem specifically, but there is a fetal hemoglobin that you produce. Your red blood cells are actually produced in your liver until you're born. And then it shifts to the bone marrow, and at that time you stop producing fetal hemoglobin, which is very good at carrying oxygen, and those genes shut down. And so these strategies are to produce either fetal hemoglobin or another component, what the beta hemoglobin protein is the one that gets deranged in sickle cell disease. There's also a hemoglobin A, and that protein can be produced by these genetic manipulations within the cell. So it's really a stunning time. And these therapies also highly effective in patients with sickle cell disease, and for the overwhelming majority of patients alleviate the symptoms of sickle cell disease. So it's a very exciting time for our patients.
Okay, you said that very eloquently, but can you break it down just overall? Give me a 10-second version that I can completely understand about how important this is and what kind of game changer this is for someone.
It basically tells us that we have incredible number of options: mismatched family donor transplants, matched sibling donors, and unrelated donors. Potentially curative therapy costs about $200,000 to $400,000. And then we have gene therapies where we can take the patient's own cells out, their stem cells in their bone marrow, take them out, genetically modify them to behave and make normal, healthy red blood cells, and then transplant them back into the patient. We have two options there with somewhat different strategies. So no patients with sickle cell disease should suffer like Desiree had to.
So the key is more options.
Absolutely.
To treat more patients that are
Bottom
going through
line.
different aspects of this.
That's correct.
We wanted you to come on this program now, shortly after this FDA approval, because that's exciting news. But it's just another step in getting this to patients. Explain to someone when something's FDA approved what that means, as far as how soon it can get to people.
Absolutely. FDA approval means that now we can use this in a clinical setting, but we have to make sure insurance companies are up to steam, and the government payer insurance companies, Medicare, Medicaid, are up to steam in being able to provide the logistical support and the finances for this. Is a very costly therapy, $2 to $3 million, depending on which of these two constructs that we choose. In contrast to transplant, which I mentioned was about $200,000 to $400,000, and so we have to, as an institution, to be able to remain whole, we have to make sure our patients can have these therapies approved by their insurance carriers. And because the patients, even if they have a 10% copay of $2 million, that's $200,000. That's beyond most families' means. And so there are a lot of logistics that have to be worked out. A small number of centers are beginning to offer this, and Zara Mahmoud Jafari, our doctor of pharmacy, is going to talk a little bit more about some of the logistics of that. It's a big production. It takes many months, and she's actually been planning. She's been the lead in our institution and planning how are we going to get gene therapy to our patients in the central region of the nation.
And that's why we wanted you to come on, because great news always comes with that question right after it from patients is, how much is this going to cost me? Am I actually going to be able to have access to it financially? So doctor, help us understand exactly how that works, the cost, and who's going to pay for it?
Yeah, absolutely. Well, as Dr. McGurk mentioned, these therapies are incredibly exciting, recently approved for patients who do not have transplant as an option. So while they're extremely exciting, they're also extremely complex. It is a one-time infusion, but it does take several months of treatment, mobilization, chemotherapy, a long hospital stay. And so with that comes an extremely large price tag. Mm-hmm. From what we understand, the lifetime cost of sickle cell disease can be anywhere between $4 and $6 million for patients who do have a prolonged survival. So while you think of $4 to $6 million as a cost of care, one would assume that 2 to 3 sounds like a bargain, but 2 to 3, to Dr. McGurk's point, is actually quite out of reach for many patients.
That?
I certainly don't. So, I think that's something that access to care and the ability to understand whether or not our insurance company colleagues will be able to cover this, and really what will the ultimate cost to patients be, will be something that we're looking at very closely, and ensuring that, we want our patients to understand all of their treatment options and ensure that they, are informed of which one is the best for them ultimately in every way, both for safety, efficacy, and of course cost.
Let's talk about the clinical trials regarding this. How effective were the treatments?
Yeah, so I'll keep it brief because we can get really in the weeds and get really excited when we go through both trials. Now, both gene therapies do have editing technology. They're both very exciting. However, there are some key differences. For the clinical trials themselves, in summary, really quick, these therapies were studied in about 35 to 40 patients each in various stages of their disease. Most patients had to be eligible anywhere from 2 to 4 vaso-occlusive events within the past 24 months. So patients who are exhibiting symptoms, certainly suffering from symptoms of this disease. And so really what both trials found, while they do work a little bit differently, both trials found that about 80 to 90%, a little over 90% did respond and actually did have a cure, which is really remarkable, seeing such small patient numbers, but seeing such incredible responses.
Dr. McGurk, you may have mentioned this, but if a bone marrow transplant is a cure, why not just choose the transplant over the gene therapy? Is it just because you can't find a donor, or is there a reason a patient just can't do the transplant and needs to try this other option through the gene therapies?
Really important question. There are different toxicities. So with a transplant using somebody else as a donor, there's a problem called graft versus host disease. It too is a very complex procedure with significant risk associated with it. However, with the strategies that we've developed, some of which I've mentioned, we've been able to attenuate significantly those risks. Nonetheless, they still exist and are not rare events. In sickle cell disease, we use the patient's own stem cells, genetically modify them, and then infuse them back into the patient. And we have seen some patients develop a secondary cancer. Now, that was with the first generation of one of these constructs, and things changed after that. They changed their methodology. We haven't seen any further cases, but there is a risk also of developing cancer in the setting of gene therapy, less so in patients undergoing stem cell transplant. So one has to sit down and have a very complex and actually generally multiple discussions with the patient and their family members so that they understand what their choices are, they know what the risk-benefit profile looks like, and they can choose wisely what suits them best.
All right, I have another question I want to talk to you about, another topic completely that you talk a lot about CAR T cell therapy here on our program, and we've met cancer patients who are alive because of it today. But just last week, the FDA announced that CAR T therapies need to include a black box warning, saying the cancer treatments may cause cancer. So from your perspective, is this black box warning necessary, and does it really change anything?
It's an area, in our field among physicians, pharmacists, nurses around the country, we were a little perplexed about how this rolled out from the Food and Drug Administration. They are planning on expanding this to all the commercially available CAR T cells. And just to put things in context, 22 patients out of 38,000 approximately who had received CAR T cell therapy had developed some secondary cancers. That may be related to therapy that they had prior to the CAR T-cell therapy, because chemotherapy drugs can give rise to secondary cancers. There are some T-cell lymphomas that have derived from this, but we know patients who have had non-Hodgkin's lymphoma previously are at increased risk for developing another type of non-Hodgkin's lymphoma, relatively rare, but it can occur. So it's important for us to be mindful of this and to counsel our patients about it. But it does seem to be an exceedingly rare event out of the 38,000 patients. And when you look at the risk-benefit ratio, we think that the potential benefit of CAR T-cell therapy greatly outweighs the potential risk of a secondary cancer.
So FDA just covering their bases.
That's correct.
Okay, thank you for explaining that. Be sure to ask your questions. You can use the chat on YouTube or Facebook. You can tweet us or email the Medical News Network. The info is right there on your screen. And there it is, the trophy in the hands of 3 of our health system's sports medicine doctors who were on the sidelines as the Chiefs took down the Ravens yesterday. That is doctors Luke Thompson, Paul Schreppel, and Scott Mullen, holding the Lamar Hunt Trophy. They're now looking forward to Super Bowl 58. We're going back again, this time in Las Vegas against the 49ers again. Hawk?
Yeah.
Where did you watch yesterday?
I watched it at home.
Yeah, of course you did. Yeah, it was pretty exciting.
Yeah.
Are you getting tired of this? I remember when they were going to the Super Bowl the first time. I mean, you could hardly contain yourself. You're not getting tired of it, are you?
No, not at all. I mean,
Okay.
they need to keep winning. It was an up and down season, so I think, they played above their seed, which is good, and won twice away from home to get there. It's very well earned, and hopefully they can bring it back.
Yeah, it was
as
a
well.
tricky season. I think that's what makes it so exciting this time around. So, all right, let's get our COVID count on this Monday morning.
Yeah, well, the COVID count was down a little bit, up a little bit this week. 23 active patients, a couple in the ICU and 1 on the ventilator. So at least it's not up into the 30s. Hoping it was going to plateau, but we'll just have to see how this next week goes. But again, as we can keep those numbers down. And we also do believe from the latest data that those people that are presenting to those emergency departments, primary care clinics, and urgent care clinics for influenza-like illness, which would include COVID-19, but also other coughs and colds, all of those people presenting, those numbers are down. So I think that is a good point of data to show that hopefully we are reaching that plateau and decreased circulation of the viruses overall.
Okay, so we keep an eye on COVID always, but there's also an estimated 16 million Americans living with long COVID. Just last week, Congress had its first ever hearing to discuss long COVID. We know it involves many different symptoms. There's a lot of different research going on right now, but it feels like we're still figuring out how this condition really works. Is that fair to say?
Yeah, and last week or within the last couple weeks, there were 2 very good basic science articles published in Nature and also in Science, which show maybe some of the mechanisms which are causing it. So if we can elucidate these mechanisms at the cellular level, we can then help to create treatments both directed to those processes, but also symptomatic treatments to help people. So those articles basically showed, again, at the cellular level, some of it involves the mitochondria and not acting as it should. The mitochondria is basically the engine of our cells creating the energy. Also showed some deposits of protein in cells, and that specifically was looking at our muscle cells, so people that get easily fatigued now doing exercise after COVID. And then there was another article that looked at the immune system and how it is kind of continually being active against maybe some viral proteins as well, causing some of that fatigue, and that was the complement immune system, which is one of our inherent immune systems as well. So totally different reasons that you're having these symptoms based on these 2 articles. We know it is complex, and there are probably other factors involved as well, but if we can elucidate some of these things and then develop treatments to it, that will be good. But I think we are starting to get answers, but I think it's still going to be a long road.
Hawk, thanks so much.
Yeah.
Let's get to some questions from our viewers this morning. Dr. Mahmoud Jafari, who sets drug prices?
Great question. Certainly isn't either of us. I think the drug manufacturers set drug prices, and there's a whole, conglomerate of things and factors that go into setting drug prices. And it depends on whether it's prescription drugs or, in our case, gene therapies. I think really what sets the paradigm for drug pricing in gene therapies and cellular therapies is what is the total cost of care, and the fact that these are one-time infusions. And so in the potential for cure, if these could, probably one of the reasons why they're so expensive is if these could cure cure the disease itself, it could decrease the total cost of care. That also being said is, just like Dr. McGurk mentioned, they are incredibly complex in terms of the logistics and ensuring that it is a properly manufactured product, the quality assurance that needs to go into these gene therapies, the shipping to and from the manufacturer. So there's a lot that goes into the pricing of these therapies, but who sets drug prices? You could get into conversations about prescription drugs, IV drugs, but these in this particular case is just the complex logistics.
Yeah, complex, which is why your job exists, it sounds like. So, Dr. McGurk, can sickle cell disease be prevented?
Not really.
Okay.
No.
Is there a certain stage in the disease that you can or cannot get certain treatments?
It's a really important question as well. Patients going into either a stem cell transplant, using somebody else as a donor, or a stem cell transplant in the context of gene therapy, have to have good organ function. You have to have good heart, lung, liver, kidney function. Now, many of the patients with sickle cell disease have had multiple hospitalizations, like Desiree. They've had organ damage, and so we have to do a very thorough evaluation to determine that we have a high likelihood of safely getting the patient through the therapy. This is really an important issue.
Is there testing? I mean, if you know when should somebody be tested, I guess, because it sounds like the sooner you know, the sooner you're getting treated. So if this runs in your family, if you know you could inherit this.
Yes. Well, children are generally tested very early on, and they know they have the diagnosis relatively early on. Most parents are informed that they have sickle cell trait, and if two parents have sickle cell trait, then they know that there's a reasonable chance that one of their children is going to be affected by sickle cell disease. They get attention early on, and the disease starts affecting them relatively early on. So you can have little kids having strokes. And,
so you would know.
Yes, right.
What if somebody does not have insurance? I mean, for this particular drug or any drug, what do people do?
Yeah, well, absolutely. You know, I think that's where this gets really tricky because they are so incredibly expensive. You know, the manufacturers, at least for these gene editing technologies, do offer patient assistance, but I doubt that it covers the entire cost of the therapies alone. So, you know, insurance is going to be the key to this, being able to receive these therapies here. Like I said, they are very expensive, and it's going to be a tricky road ahead for those that are uninsured.
Sounds like we will have you back on to explain a lot more. Like you said, we could really get in the weeds, and it sounds like we need to. Let's get to our final thoughts today, and just what do we want everyone to take away from this conversation? I'll let you start with us.
Yeah, absolutely. He usually steals my thunder, so I think
there you go.
the biggest thing is hope and potential. And you know, the CRISPR technology is itself incredibly unique. It's the first of its kind to be FDA approved, and really, it's the potential for other genetic disorders to utilize the same technology. You know, the researchers who looked into CRISPR technology recently won a Nobel Prize, so you know that they're doing really great and remarkable work. So for me, it's hope and potential for patients who've been suffering for an incredibly long time.
All right, Dr. McGurk, you have to follow Dr. Mahmoud Jafari.
That's impossible. That was very well stated. There's a great injustice. I think that if you look at the funding from the National Institute of Health for research in sickle cell disease, it's 3 times less than another rare disorder, cystic fibrosis, which occurs predominantly in Caucasian populations. And as Desiree pointed out, nobody believes she had pain when she went to the hospital. This is a common theme for patients with sickle cell disease. So there's a lot of prejudice, a lot of bias, and they're already suffering from a terrible disease. In addition, many of the affected communities, African American community, Hispanic American community, are poorly informed that there are curative therapies potentially available to them. And so on April 20th of this year, we'll have a large conference. The first talk is going to be Dr. Robert Cribbs talking about sickle cell disease baseline. I'm going to talk about transplant and sickle cell disease, and we will have Desiree at that platform as well. And we're inviting political leaders, the mayor of Kansas City, the mayor of Kansas City, Missouri, and Kansas City, Kansas, and other political leaders in our state and our region to come to this. Hopefully they'll attend. It's critically important because we need them to help amplify the message that there is hope, as Dr. Mahmoud Jafari pointed out. There is great hope for our patients that they can live a normal, healthy life go to nursing school and help other people like Desiree is really remarkable.
Well, I appreciate you talking not just about how you're treating patients, but really the most important is that the injustices and the limited access. So thank
Absolutely.
you. We'll keep talking about this further. Thank you both for being with us.
You bet. Thank you.
Thanks to all of our viewers for being with us today as well. We'll see you back here on Wednesday. Coming up Wednesday on Open Mics with Dr. Stites. After nearly 4 years of the COVID pandemic, where do we stand now? I'm Jessica Lovell on the next Open Mics with Dr. Stites. The virus is still out there and vaccination rates are lagging. Hear what leading doctors across the metro are seeing inside their hospitals. Wednesday at 8.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.